Morning, everyone, and welcome to the Arineta-sponsored SCCT webinar. Cardiac CT is continuing to grow with new scientific evidence, the new multi-society guidelines for chest pain, and with expanded insurance coverage. However, much of the utilization today of cardiac CT is in the academic or tertiary care hospital setting. With COVID and with patients increasingly seeking care in an outpatient setting, our topic today is especially relevant: enabling cardiac CT at the point of care. My name is Scott Schubert. I'm the CEO of Arineta, and I'll be the moderator for this symposium. After a brief introduction, we'll have two presenters to discuss their office and outpatient practices. The first presentation is focused on cardiac evaluation and diagnosis, and the second presenter is focused on cardiac CT for interventional planning. Then I'll give a third presentation to give a technology overview of the Arineta Cardiograph CT scanner. Our first speaker is Dr. Sujith Kalathiveetil, a cardiologist at Duly Health and Care, which is an outpatient multi-specialty practice in suburban Chicago. Dr. Sujith is the Director of Advanced Cardiac Imaging at Duly. Our second presenters are Dr. Tony Das and Dr. Imran Baig, who are interventional cardiologists at Connected Cardiovascular Care, or C3, in Dallas, Texas. C3 is an interventional OBL, or office-based lab. Dr. Das is the founder of C3 and is the Director of Peripheral Vascular Interventions. And Dr. Baig is the Director of the Structural Heart Program at C3. Arineta is a team of world-class technology pioneers who are 100% focused and dedicated to cardiac CT. Our vision is to grow cardiac CT as the frontline diagnostic test for managing cardiovascular disease, to thereby significantly improve patient outcomes and lower healthcare costs. We are the developer and manufacturer of the Cardiograph, the world's first dedicated cardiovascular CT. The system is regulatory cleared and installed in the major markets around the world. And we are proud partners with GE Healthcare to provide full finance and service solutions for your cardiovascular practice. Cardiac CT is dramatically underutilized today, as shown on the left, and lacks access in many point-of-care settings. A recent study in the US Medicare population showed a 43-to-1 ratio of nuclear myocardial perfusion studies versus cardiac CT. So, despite the impressive advances in cardiac CT technology and hundreds of scientific studies demonstrating cardiac CT's clinical outcomes, the routine of adoption of cardiac CT is lagging. So what's needed to improve access to cardiac CT? On the right, you can see that today's cardiac CT systems, shown with the blue arrow, are whole body CTs that have an intrinsic trade-off. They are either 64-slice systems in the lower right that are more affordable, or they are high-performance systems in the upper left that are very expensive, often upwards of $2 million. What's needed is a cardiac CT system that delivers both the best image quality and is affordable. And that's the goal of the Arineta Cardiograph system, which is purpose-built for cardiovascular CT to provide the highest performance, affordability, and is small enough to fit in an office, cath lab, or mobile bus. And we believe the Cardiograph is the opportunity to improve access to cardiac CT at the point of care. I'd now like to transition and introduce Dr. Sujith to talk about his practice at Duly Health and Care.
Thank you, Scott. Good morning, everyone. My name is Sujith Kalathiveetil. I'm a cardiologist with Duly Health and Care, and I'll be speaking today about enhanced cardiac access in an office-based clinic. So Duly Health and Care is a private, physician-owned, multi-specialty practice of 1,000 physicians with approximately 50 cardiologists. We offer a range of services across primary and specialty care, and we serve over 2/3 of the Chicagoland suburbs. Our core philosophy at Duly is to provide high-quality care that is outpatient-based and cost-effective for maximum value. And this is driven by the fact that we have a sizable Medicare Advantage population. Duly specialties are traditionally heavily outpatient-based. Cardiology by its nature, however, has a significant inpatient volume, and this has always created a major challenge for controlling costs in the management of patients with heart disease. Chest pain is particularly problematic. So historically, our triage nurses had sent all of our patients with chest pain immediately to local emergency rooms where they were typically admitted for inpatient evaluation. Many of these patients did not have life-threatening chest pain. Hospital admission was often unnecessary. What actually was needed was timely triage and evaluation. So to address this, Duly created a cardiac evaluation center for patients with non-life-threatening cardiac symptoms, including chest pain, provide rapid evaluation and on-site testing. By providing expedited outpatient evaluation, our goal was to reduce healthcare costs and provide greater patient satisfaction. So everyone's very familiar with the 2021 AHA-ACC chest pain guidelines. In these guidelines, coronary CTA is the only class 1 non-invasive test with level A evidence for diagnosing coronary artery disease and guiding treatment decisions. So coronary CTA essentially became the first-line test for the diagnosis and management of chest pain in patients without a prior diagnosis of obstructive coronary artery disease. So when these guidelines came out, it made it clear to us that acquiring our own cardiac CT scanner was vital for our practice. So Duly purchased an Arineta GE cardiograph CT scanner and opened the CEC in January of this year. We chose the cardiograph CT for a variety of reasons. First, it has a smaller form factor that was very space efficient and great for our ambulatory setting. Secondly, it has a smaller field of view that reduces radiation dose and limits visualization of non-cardiac anatomy. And again, we're using this as a dedicated cardiac CT scanner. Third, it's cost efficient as compared to general purpose CT scanners, yet still provides excellent image quality. So this is our typical workflow at the Cardiac Evaluation Center. Step 1, a patient calls or presents to a Duly primary care physician, cardiologist, or urgent care center with chest pain. The patient is then referred to our evaluation center. We have a triage nurse at the evaluation center who screens the patient to make sure that inpatient evaluation isn't indicated. Second, the patient is then seen at the CEC within one working day, and typically they're seen the same day. As soon as they arrive, EKG and labs, including a troponin, BMP, and CBC are checked immediately, and the patient is placed on telemetry. They're then evaluated by a cardiologist and/or an APP. So this is the screening questionnaire that our triage nurses use when a patient is referred to the Cardiac Evaluation Center. We first screen to see if the patient is having severe or unstable chest pain, and we use the AHA guidelines for that. So severe chest pain is 8 or greater out of 10 in severity, crushing, or if there's a sense of impending doom, any of those things trigger activation of EMS. Second, we ask the patient if they have a prior diagnosis of obstructive coronary disease. And if so, if these symptoms are similar to what they had before, once again, EMS is activated. Third, we screen the patient for COVID, fever, cough, or COVID positive in the last 10 days. And again, if they say yes, they are sent to the emergency room. If they say no to that question, then they come to the Cardiac Evaluation Center. Step 3, if the patient is identified to be an appropriate candidate, coronary CTA is performed typically on the same day. We use rate control with a combination of oral metoprolol as well as IV metoprolol, diltiazem, and ivabradine. If the patient has an elevated heart rate, 90 to 120 beats per minute on presentation, we typically have the patient return the next day after being pre-medicated with oral metoprolol. The next step is that all walk-in coronary CTAs are read prior to the patient being discharged. Our goal is to discharge the patient within 2.5 hours of presentation. So Duly is part of the HeartFlow Unlimited program. All coronary CTAs performed at our CEC have CT-FFR performed. All walk-in patients are flagged as urgent, and we have a 1-hour FFR turnaround time. Patients with obstructive coronary artery disease are started on guideline-directed medical therapy and arranged for prompt outpatient cardiac catheterization, typically within 72 hours. Patients with non-obstructive coronary disease are started on guideline-directed medical therapy as well, but they follow up in the office in about 2 weeks. So our cardiac evaluation center is open Monday through Friday from 8 a.m. to 5 p.m. We typically have 10 elective outpatient CTAs scheduled daily, and these are a combination of coronaries, pulmonary veins, valve studies, and thoracic aortic studies. But we also have 5 additional CTA slots reserved for walk-in coronary CTAs and patients who present with chest pain to our CEC. And we typically do 2 to 3 walk-ins a day. We've done as many as 5 in a day. We see 14 to 20 patients daily at our CEC. Since opening in January, we've had 1,434 patients be evaluated at our CEC. We've performed 1,467 cardiac CTs since opening and using our cardiograph. 1,173 of these were coronary CTAs. Our heart flow FFR acceptance rate for our coronary CTAs is 96%, which is the highest in our geography. Now, in addition to chest pain, patients are also referred to our cardiac evaluation center for hypertensive urgency, hemodynamically stable rapid atrial fibrillation, hemodynamically stable decompensated heart failure, and urgent pre-op cardiac evaluation. We offer echocardiography, treadmill stress testing, mobile cardiac telemetry, also at our CEC. So let's go over some case studies. These are all patients who presented to our CEC recently. So our first case is a 60-year-old male with well-controlled hypertension, hyperlipidemia, who exercises regularly, went on a trip with his family, and during this trip, he walked a 3-mile hike with incline. 1 mile into the hike, he experienced dyspnea associated with chest tightness. He stopped and rested for about 15 minutes with resolution of his symptoms. He completed the remaining 2-mile hike without incident, and his symptoms did not return. The next day, he thought of his mother, who died of a myocardial infarction in her early 60s. So he became concerned and contacted his primary care physician, who referred him to the cardiac evaluation center. When he arrived at our CEC, EKG was done, which showed sinus bradycardia at 53 beats per minute, but was otherwise normal. Labs, including a troponin, were normal. So a coronary CTA was performed within 30 minutes after arrival, since he had such a nicely well-controlled heart rate. What we found, when we performed the CTA, we used our standard protocol of a 1-beat acquisition, 0.24 second rotation, and our radiation dose was fairly low, 2.4 millisieverts. And we found a 70-99% severe stenosis with mixed plaque involving the proximal LED. We performed FFR on the patient. Again, the results were back within an hour. And this showed a hemodynamically significant lesion in the proximal LED, also affecting flow in the second diagonal branch. The findings were discussed with the patient at length. He was started on aspirin nitrates. We did not start a beta blocker, as heart rates were already in the 50s, and he was scheduled for outpatient cardiac catheterization. The total visit time for all this was 1 hour and 45 minutes. Our second case is a 27-year-old male without any obvious cardiovascular risk factors. He recently had an LDL of 94. Labs showed he's not diabetic. He's a non-smoker. But 1 month prior to presentation, he caught COVID-19. He was unvaccinated, and he developed moderate symptoms at the time of the infection of fevers and cough, which resolved after 3 days. However, after recovery, he began experiencing intermittent chest discomfort that radiated to his left arm. Described as a substernal burning tightness pain. He only felt symptoms with exertion, specifically when he'd walk up a flight of stairs. He did not feel any symptoms at rest. He relayed his symptoms to his primary care physician, and an exercise stress echocardiogram was ordered. I would start by saying a stress echocardiogram probably was not the test I would have ordered, but again, this is how he presented. His resting EKG was normal, but with exercise, he developed 3 millimeters of horizontal ST7 depression at 8 minutes into exercise that resolved at 2 minutes into recovery. His baseline echocardiogram showed normal left ventricular systolic function and wall motion. His ejection fraction was 60%. His stress echocardiogram basically showed extensive wall motion abnormalities developed in the entire LAD distribution. And he developed 6 out of 10 chest pain with exercise that resolved completely in recovery. So given the findings, the patient's primary care physician was immediately contacted by the reading cardiologist. As his EKG changes and symptoms had resolved completely, he was sent to our cardiac evaluation center for evaluation. And I would point out that if his EKG changes had persisted or if his pain had not resolved, he would have been sent to the ER via EMS. Luckily, that wasn't the case. Upon arrival at our CEC, the patient remained pain-free at rest. A repeat resting EKG appeared normal, and we did check labs, including a troponin level, which were normal. So given that he remained clinically stable and his troponin level was normal, a coronary CTA was performed. And what we found is that the patient had dissection involving the proximal LAD without any evidence of atherosclerosis in the coronary artery. So he appeared to have developed SCAD involving the proximal LAD in the absence of atherosclerotic coronary disease. CT-FFR again was performed and showed a hemodynamically significant lesion in the proximal LAD. The patient was then directly admitted to the hospital for further evaluation. As we felt he was clinically stable, we did not activate EMS. We actually bypassed the emergency room, had him directly admitted to our hospital service with cardiology and consultation. He spent a total of 2 hours in the cardiac evaluation center having all this testing done. After arrival in the hospital, he was started on antiplatelet therapy and beta blockade, and he was watched for 2 days in the hospital and remained clinically stable. He had been seen by cardiac surgery as well as our interventionalists, and as he remained stable, we felt there was no urgent need to attempt the risks of revascularizing him. He was discharged home with instructions to avoid heavy exertion for 30 days, and we did repeat a coronary CTA after a month, which showed healing of his dissection, and he was referred for phase 2 cardiac rehabilitation. Case 3 is a 59-year-old male with a history of elevated coronary calcium score. He had a score of 800 in 2020, and he was noted to have intermittent substernal chest pain for the past 2 months. The primary trigger for his pain, interestingly, was emotional stress. He does have severe osteoarthritis of his right knee and has been less active, and he was unable to exercise on a treadmill. So his primary care physician, again, looked at these symptoms and ordered a Lexiscan nuclear stress test. Again, if he had presented to one of our cardiologists, we likely would have started with a coronary CTA, but again, this is how events transpired. The stress test basically showed no ischemia and a normal ejection fraction of 57%. So he was managed conservatively, but his symptoms continued to increase in frequency over the next month, and he was sent to our cardiac evaluation center. Upon arrival at our CEC, labs, including a troponin, were checked and were normal. But given his new right bundle branch block and recently normal stress test, we wanted to exclude other things as well, so a D-dimer was also checked, and that was normal. A coronary CTA was then performed 45 minutes after arrival. So again, here, patient, larger patient, BMI of 35, heart rate of 60, again, 1 beat acquisition, 0.24 second rotation, can use fairly low dose for a patient this size, 2 millisieverts. And what we found was he had moderate diffuse disease in the proximal mid-LAD with a severe stenosis in the very distal apical LAD. Non-obstructive disease was noted in the circ and RCA. CT-FFR demonstrated hemodynamically significant disease in the very distal apical LAD, as we saw on the axial images here. The FFR value was indeed positive, but again, at the very distal tip of the vessel. The above findings were discussed with the patient. Aggressive medical therapy was recommended given his distal ischemia. The patient was started on beta blocker and nitrates and discharged with outpatient follow-up. He was seen in our office by one of our APPs a week later, and his symptoms had improved significantly. Again, all of this was accomplished within an hour and 30 minutes of presentation to our CEC. So in conclusion, the Duly CEC has allowed us to offer expedited outpatient evaluation of heart disease. Stable chest pain has been a major focus of our CEC, and coronary CTA is heavily utilized as our preferred first-line test in patients without a prior diagnosis of obstructive coronary artery disease, in line with the 2021 ACC-AHA chest pain guidelines. Our Arineta GE cardiograph CT scanner has been one of the cornerstones of our cardiac evaluation center, and Duly is actually planning to open 2 more cardiac evaluation centers in the next 2 years with cardiographs. Thank you for your attention. I'll now pass this off to Dr. Das.
Thank you very much, Dr. Sujith. That was a very interesting overview of your chest pain center. Thank you for that. Good afternoon and welcome to this webinar for Arineta. I'm Dr. Tony Das, an interventional cardiologist in Dallas, along with my partner, Dr. Imran Beg. We're going to spend the next 15 minutes going through the role of CT for interventional cardiologists in the structural heart team. Let me just introduce our practice for just a minute. We're Connected Cardiovascular Care Associates. We are a multi-site, multi-hospital cardiovascular team. We deal with imaging, interventional and peripheral vascular disease, and structural heart disease, and focus on digital health as a way to untether our patients and to be able to care for them remotely. We have clinics in Dallas and Rockwall, Texas, and the team has been blessed with many accolades, including Key Magazine's Best Doctors for 15 years, nominated as the best medical practice in Dallas by the Dallas Morning News, among others, including Texas Monthly Best Doctors. And we're most proud of being the personal cardiology interventional practice for former President George W. Bush. With that, I'll go on and talk a little bit about what I think is the value of CTA in interventional cardiology, and Dr. Begg will help us with the structural heart component. So let's start with a case. I think it's important to display what we do on a daily basis by using a case example. This is a 65-year-old man who came to us very recently, had a history of type 2 diabetes. He had symptoms of chest pressure, but the story was not classic for cardiac pain. He did have a very stressful job. In addition, we had a nuclear stress test from several years ago, which showed really no ischemia and mild inferior soft tissue artifact. Nuclear scan more recently showed to be normal and had a normal echo. He does have a family history of coronary disease, and he was a former smoker. So this nuclear scan, which was performed just a few weeks before, showed some inferior soft tissue defect. You can see some abnormalities there in the inferior splash images, but nothing that really got our attention. The patient continued to have some symptoms, and we decided to go for a CT angiogram. The CT, which was a non-Arineta CT scan, showed heavily calcified right coronary artery, which ultimately led to a fractional flow reserve evaluation. That FFR showed a severe abnormality in the right coronary artery, but as you can see from the images on the right side of your screen, the right coronary appeared to be quite small, perhaps even non-dominant. So in this scenario, having the information from the CT and the FFR and the patient's equivocal story, it felt like going forward with an angiogram may make sense to be able to identify what the abnormality was. So now we have all this non-invasive testing to tell us what's going on. This highly calcified area really is well visualized using the Arineta CT scanner, in addition to which patients with previous stents can have very significant assessments even with CT angiography, which has always been thought to be a limitation for CT. This is an example from Budapest that shows significant coronary disease, significant calcification, but still excellent evaluation in a patient with a very high BMI. In addition, visualization of the lumen with patients that have stents can also be visualized on a scanner like this, and you can compare that to the images that I just showed you in the previous two slides. In addition to that, when we go to invasive angiography, the CT angiogram looks very much like the coronary angiogram in these patients. And this is an example again from Budapest, and we'll get to our patient in just a few seconds. So you can see how it correlates pretty significantly. So here's our patient now who comes in, has a coronary angiogram, and this left image you can see we're shooting the left coronary artery, but the right is filling up. At first you think perhaps that there is some cusp dye that's filling the right coronary artery, but you realize that no, this is actually quite a large right coronary artery, and it's getting collaterals from left to right, signifying a significant disease in the right coronary artery, which was similar to what the CT angiogram showed. In addition, a selective injection of the right is a little equivocal as far as what the severity of the right coronary ostium is, but you can see here significant amount of plaque in the intravascular ultrasound imaging. So CT angiography, or if we did not have CT angiography, we would not have been this clued into the severity of what was going on in this right coronary artery, and may have just called this relatively normal and moved on. But having that CT and the CT FFR made us go further. In addition, what we find is that the ostium is quite severe. This is a balloon and stent of the ostium of the right coronary artery, followed by an angiogram that shows that the vessel is now widely patent. And at the conclusion of that, what we determine is when we go back and see, well, wait a second, did we actually improve this collateral filling to the right coronary artery? It turns out that there is a significant improvement, and now here's the injection to the left, and the right's no longer filling. So I think we have completed our task at revascularizing this patient. But without CT, CT-FFR, and having that extra knowledge, we probably would not have gone this far in taking care of this patient. And clinically, the symptoms also went away. So let's talk a little bit about CT with cardiac and vascular conditions. Half of our practice is vascular, and one of the things that we often try to identify is whether the patients have significant vascular disease that would require revascularization. And in these conditions, we will start with a duplex or a lower extremity ultrasound, and then be clued into whether or not there's a reason to go with CT. As you can see, with CT and Arineta CT in the carotid arteries, you can have wonderful visualization and be able to plan procedures, which is what we're able to do in the coronary space as well. So having CT and CT angiography as a planning tool really does a couple of things very importantly in both the cardiac and vascular space for us. One, it identifies those patients that are safe to go to outpatient settings, which were not in the hospital, say, for instance, an ASC or OBL. In addition, it allows us to plan the study and plan the intervention. On the coronary side, you could see knowing that we had to deal with that right coronary from that CT gave us all the assurance that that's the only place that we needed to head to be able to deal with that. And these carotid cases, very similarly. In addition, other vascular conditions that we look at are renal artery stenosis. You can see excellent visualization of the renal arteries in this patient, as well as visualization in these axial images of the CT, identifying patients with renal artery disease and renal artery stenosis. We spend a fair amount of time doing infra-abdominal aortic work as well, and you can see the CT angiography of the abdominal aorta, stent and stent graft, and even identification of endoleaks in a patient that has an elevated heart rate and beautiful imaging of the thoracic and abdominal aorta. So we use CT and CT angiography for coronary, peripheral vascular, but also for structural heart disease. I'm going to leave the last 5 to 7 minutes with Dr. Baig to help us understand what CTA can do in the structural heart world. Thank you very much to our CEO from Arineta, Scott Schubert, and for the CCCT meeting for having us. Dr. Baig, why don't you take it from here?
Thank you, Tony, for this opportunity. It was a great case presentation. I want to talk a little bit about structural heart diseases, what Dr. Das has said. I'm the director of the structural heart program here at Connected Cardiovascular Care. A little bit more insight about structural heart disease and in general aortic stenosis. As we all know, the prevalence of aortic stenosis is rising sharply with increasing age and is approaching 25% of all adults older than 65 years. And out of that, 2 to 5% have severe aortic stenosis. Now, the prevalence of aortic stenosis is expected to triple by the next 30 years in high-income countries due to the aging population. With these new findings, as you can anticipate, the burden related to aortic stenosis, it will become unsustainable for our healthcare systems, and that transformative actions should be implemented urgently to mitigate this burden. So at Connected Cardiovascular Care, we've been at the forefront of virtual valve clinic. Our goal is essentially to make quality care accessible to remote locations. As you know that with TAVR planning, patient selection, device selection, sizing, and access relies heavily on non-invasive imaging. CT imaging is widely used for pre-procedural assessment of aortic root. As you look at this 77-year-old male example, when we have somebody with a TAVR planning, we look at what we call a bunch of different things, starting from the LVOT calcium and the measurement of the area, as well as the annular area with respect to the coronary heights. As you look at the right coronary osteo over there, as well as the left, and sinuses. These play a very important role in a selection of valve, as well as more importantly, the size of the valve. In addition, we need to make sure that these devices fit appropriately and there's not significant paravalvular leak. So using Arineta's cardiograph, this CT essentially has less centrifugal force when the gantry rotates fast with a 0.24 second rotation speed, this combining with a 120 millisecond of temporal resolution. It provides actually great 4D imaging of the heart for a whole heartbeat. Ranging from the aortic annulus all the way to the femoral arteries. As we know, femoral arteries are very important in planning and appropriate execution of the TAVR procedure. Also, if you go to the next slide, I believe there's another slide. This is just basically looking at the iliacs as well as down the way to the femoral system, as well as showing you the heights of the coronaries in relation to the annulus. So this Arineta has this reduced gantry size. It's with this easier installation. It requires a more modest room. With the growing and ever expanding aortic stenosis population, like I've talked about earlier, we hope to reach out to a greater segment of population with the hope of being able to establish quality imaging in offices and with time, maybe mobile units. And this applies to every other aspect of structural imaging, including left atrial appendage devices, paravalvular leaks, ASDs, PFOs, and so on. So I think this is a great tool for us in our basket, and we're looking forward to using it more.
Great. Thank you very much, Imran, for that excellent overview. It's our pleasure to continue with Scott Schubert, the CEO of Arineta, talking about the cardiograph technology overview, followed by a question and answer session. Thank you very much for your attention.
Thank you, Dr. Das and Dr. Baig. In this third presentation, I'll give a technology overview of the cardiograph, the Arineta dedicated cardiovascular CT scanner. The cardiograph is the world's first dedicated cardiovascular CT scanner that enables cardiac CT at the point of care. The system provides the highest performance, affordability, and a small footprint for easy sighting in an office and outpatient setting. I've personally been leading engineering teams in cardiac CT system development for more than 20 years. And I can say that the cardiograph, in my opinion, is the highest performance cardiovascular CT system available. The specifications of the system are impressive. The system provides whole heart, one heartbeat scanning in a single rotation. The rotation speed is 0.24 seconds with a half scan acquisition, delivering a temporal resolution of less than 1/8 of a second or 120 milliseconds. The whole heart, 14 centimeters, is covered in a single rotation with 560 slices per rotation. And the system has excellent specifications in spatial resolution, high power for high BMI patients, and low dose imaging with a focused field of view for cardiovascular applications. There are three primary technology innovations and differentiators on the cardiograph. The first is called stereo CT. This novel approach to cardiac imaging uses two tubes to image both the superior and inferior portions of the heart in an alternating manner. And with two tubes, we can get whole heart coverage from a single rotation with less cone beam artifacts and more affordability by having a smaller detector with this geometry. The second key technology on the cardiograph is called the focused field of view. The focused field of view is a 250 millimeter high resolution field of view for imaging the cardiovascular structures. And the system has lower resolution detectors that are attenuated in their radiation dose outside the heart to provide less incidental findings in the lungs and deliver an overall lower dose for the patients. The third key technological innovation is the ultra-fast rotation speed of 0.24 seconds. This is enabled by a short distance between the tube and detector that enables the gantry to rotate extremely fast. This also provides a higher photon flux for a given tube power because the tube and detector are closer together, and this provides advantages for high BMI patients. The small size also provides advantages in terms of size, weight, and installation cost for an office outpatient setting. As shown here, the cardiograph is 40 to 50% smaller than other general purpose CT scanners, enabling it to fit in an office or cath lab setting. Several scientific studies have been performed comparing the cardiograph to other general purpose CT scanners. These studies focused on the clinical performance, especially for high heart rate and variable heart rate patients in AFib, where the cardiograph demonstrated excellent and in some cases superior clinical performance. The cardiograph is not just a heart scanner. The cardiograph provides a full cardiovascular imaging capability. including the aorta, TAVI studies, brain CTA and angiography, and carotid studies. So you can do your heart and vascular imaging on the scanner. We are also enhancing the system to provide extended field of view for lung imaging to do cardiothoracic applications. This is important because 4 of the top 6 killers are either cardiovascular or cardiothoracic diseases, and we want the system to be extended into prevention and wellness. The system is also the only premium cardiac CT with advanced one-beat cardiovascular imaging that can fit in a mobile RV bus. And the first RV bus configuration will be deployed in the Los Angeles area later this fall. This enables cardiac CT in a rural and community hospital setting for the first time. I'd like to briefly talk about some of the financial and operational considerations to adopting the Arineta CT in an office or outpatient setting. We are happy and able to do a pro forma analysis with you for your practice and customize it for you. Typically, we see that the break even for acquiring an Arineta CT and making it financially viable is at about 4.5 patients per day. And in fact, if you can achieve up to 8 to 10 patients per day, the net cumulative cash flow can be quite financially attractive. In addition, because we want to enable cardiac CT at the point of care for new office practices that have not adopted cardiac CT in the past, we have also announced a pay-per-use financing model to allow you to install cardiograph now without the upfront equipment cost and without putting your own practice capital at risk. So pay-per-use can allow you to adopt cardiac CT earlier than you might have otherwise waited for your budget to be ready and available. So in summary, we at Arineta are excited that we are enabling cardiovascular CT for the first time at point of care. We'd now like to take any questions that you might have for any of the speakers.
Yes, we're here for the live Q&A session. Again, my name is Scott Schubert. If you would submit your questions via the chat in the Zoom, we can take the questions. I've gotten some directly sent to me as well that I will also moderate. I'd like to thank Dr. Sujith, Dr. Das, and Dr. Baig for their outstanding presentations. And we are all extremely passionate to make cardiac CT the frontline test for managing cardiovascular disease. And we believe that this needs to be done in an outpatient setting at point of care, which has really been the focus of this symposium. So the first question I'll take is for Dr. Sujith, but Dr. Das, you can weigh in here as well. The question is about your backlog. Before you got the cardiograph, kind of what was the wait list, wait time for patients when you had to refer them elsewhere? And how have you reduced that wait time and backlog for your patients, Dr. Sujith, with the CEC?
Thanks, Scott. So yes, we were typically waiting 1 to 2 weeks to get a patient in for a coronary CT at our hospitals just due to scheduling issues. As long as we have insurance approval, we can get a patient in for a coronary CT at our CEC within 24 hours, frequently on the same day, assuming their heart rate is in a reasonable range.
Great. Dr. Das, do you have anything to add to that?
Yeah, Dr. Baig and I also experienced significant delays in getting CTs ordered, particularly at one of our major hospitals, which is also a teaching center at the Baylor Scott and White Heart Hospital. It's as much as 30 days. And frequently what happens is the patients will give up and end up not getting the CT done. The other thing that we know is that in the system, the Baylor Scott and White Hospital system, there are about 10,000 patients a month that go through that system through the ERs. And in those ERs, they come in with chest pain as the diagnosis. And only 18% of those patients end up seeing a cardiovascular specialist within a reasonable amount of time. So it's not just a backlog of the CT is the backlog of the patient flow. So if you were to call Sujith's office, or if you call Dr. Beg's office, they may tell you it's 3 months before you can see these experts. And meanwhile, if we had an opportunity for the CT to be part of the imaging chain, particularly after the chest pain guidelines suggest it's a level 1 indication, we need access to be able to triage these patients more appropriately. So that's another way where we're looking to help partner with the hospitals and partner with emergency rooms and other places that are seeing these types of patients.
Great. The second question that I got privately here, again, I'll start with Dr. Sujith for this one. You mentioned that you're performing nuclear perfusion studies. Can you comment on, now that you've got the cardiograph scanner in your practice, kind of your triage for those two tests, and what has been kind of the downstream impact on some of your nuclear studies?
Yes, Scott, there has been an impact on our nuclear studies with the advent of our cardiac CT program. The vast majority of our nuclear perfusion studies are being done in patients with the history of prior coronary revascularization. We've had about a 30% drop in our nuclear volumes since acquiring our cardiograph, and that's due to a combination of things. First is that we're really utilizing coronary CT as a first-line test in patients without a prior diagnosis of obstructive coronary disease. But the second thing is that insurance providers are really heavily pushing us toward coronary CTA and putting up a lot of resistance for authorizing nuclear stress tests.
Great. Dr. Das, one more question for you, and then I'll go to a couple of the questions in the chat. The question that I got for you was, what do you consider the role of cardiac CT to make your cath lab more efficient? How do you view the fact that you'll have pre-planning anatomical information to guide your intervention? How do you think that's going to improve or change your efficiency or your utilization in the cath lab?
Yeah, Dr. Beg and I have had this conversation before. I think that, you know, pre-procedural planning is really the main reason why procedures go well, and you can anticipate complications and other issues that may occur. So if you have a CT, you have the anatomy, and you also understand through FFR what the physiology is, so you avoid lesions that you don't need to deal with, number one. Number two is you can then risk stratify that patient into high, medium, or low risk, and then you can change the site of care, which may actually, as time goes from, you know, fee for service into fee for value, that you might be able to bring more of these patients into an ASC lower cost setting. So in general, the overall advantage of something like this is that it gives you higher level of care with better understanding of what you're going to run into and anticipating that, and also reducing your potential risk and complications. Dr. Beg, would you agree?
No, yeah, I couldn't agree more. I think, you know, pre-procedural planning is 80% of the case going well. And I think it also tells you what equipment that we need to ask for, and what we're going to get ourselves into. So I think it's very key that we have this information before we walk into the cath lab.
Great, thank you. I'll take two of the questions that came in from the chat, and I'll just remind everybody, please submit your questions to the chat, and we'll get to them during the next 10 to 15 minutes that we have available for the webinar. The first question came from Dr. Vikram. It was about the cost of the system. So these questions are always difficult to generalize, but what I'll say is that overall, the cardiograph and the Arineta CT can be acquired for less than $1 million overall. That includes not only the system, but all the accessories that you need in order to be operational with your cardiac CT practice: the ECG, the injector, the 3D visualization workstation, applications training, install, and warranty are all included in that kind of less than $1 million kind of overall cost. And then, as I mentioned in my portion of the webinar, we also at Arineta offer a pay-per-use financing approach, so that you can essentially defer that upfront cost and have no upfront cost, and then kind of pay on a pay-per-use basis as your procedure and your practice grows. So it's a very exciting risk-sharing opportunity between Arineta that we've invested in your practice to get the scanner in your hands and grow your practice from the beginning. The next technical question that came in on the chat, this is from Dr. Zihua Chi. The question is, during a rotation, are both tubes on at the same time continuously throughout a rotation? So the answer to this question is that the two tubes are not on simultaneously. The two tubes alternate. The superior tube and the inferior tube are what's called gridded. They alternate in microseconds back and forth to image the superior and inferior portion of the anatomy. And this happens millions of times throughout the scan as you're rotating because we need high temporal resolution of both the superior and the inferior portion of the anatomy. So we take about 1,000 views as you rotate, and each tube is taking 1,000 views of the superior and inferior portion of the anatomy. They are not on at the same time because then the detector would not know the source of the X-ray. So each tube needs to be on in isolation in order to perform the image reconstruction on the system. Okay. The next question on the chat was from Dr. Nguyen. The question is, do you guys give metoprolol or nitroglycerin in cases where patient's heart rate is higher when doing a CCTA scan? Dr. Sujith, can you describe your patient preparation protocol with the cardiograph?
Sure. Yeah. Even though the cardiograph has a superior temporal resolution, we still find that good heart rate control gives better quality images. So at our CEC, we use pretty much every trick in the book. We use oral metoprolol for scheduled outpatients. We actually pre-medicate them. For people who arrive, we just give them oral metoprolol. We also use a lot of ivabradine. We find Corallenor to be an excellent agent, being that it's blood pressure neutral in people who are in sinus rhythm with an elevated heart rate. And we also even use diltiazem as needed as well, too, if there's still blood pressure to work with. So all of those things help. And I think good heart rate control is always going to give you a better quality study. In regards to nitroglycerin, yeah, we try at a minimum to give 0.4 milligrams of sublingual nitroglycerin to patients. And if they have the blood pressure to work with, we actually use 0.8 milligrams. There's data actually that in the FFR literature that actually increases the accuracy of FFR.
Would you care to comment? The question was specific to CCTA scans, but I think there's a number of the structural heart procedures where beta blockers are not used, and maybe you can describe, in those clinical scenarios, what your image quality and clinical performance has been.
I mean, in general, we'd like lower heart rates. I mean, provided the patient has appropriate heart rates and is not significantly fast, we don't necessarily resort to giving beta blockers. But then, again, I agree with Sujith that the lower heart rate, the better. So it's patient to patient and is dependent mostly on what we're actually looking for in terms of structural heart disease workup and what the timing is. But for the most part, and if we're talking about Arineta in general, we don't necessarily feel the urge to drop metoprolols or IV or oral if the patient has appropriate heart rate, considering it's not significantly tachycardic.
I agree with Dr. Baig. The aortic valve annulus and the left atrial appendage, that's where we use CT for our structural planning. They're much larger structures than the coronary arteries, so we can be more tolerant of higher heart rates there to begin with. We like to keep, if the heart rate's over 100, and there's blood pressure to work with, we'll try to, give some rate control there. But again, particularly in the aortic stenosis patients, we're trying not to get the patient in danger by over medicating them, So patient safety always trumps, a lower heart rate. But yeah, when the heart rates are elevated, we will try to do a little bit of rate control, but it's a different level of expectation for where we want the heart rates to be with structural CT versus coronary CTA.
What I'll add to that is the technical implementation of the cardiograph for high heart rate patients is exceptional, best in the industry, in my opinion. There are 4 key things that the scanner does in order to manage higher and variable heart rate patients. The first we talked about, which is the 120 millisecond temporal resolution and short exposure time. Number 2 is the single heartbeat scanning. This allows good mitigation of any heart rate changes. In a helical study, which the cardiograph does not use, if the heart rate changes from beat to beat, you can't go back because you'll lose the bolus. But in a single heartbeat scanner, you can capture and freeze that motion. The scanner also has bad beat rejection, what's called arrhythmia management, where because the table is stationary during the scan, if an arrhythmia occurs, then the scanner can halt the acquisition and wait based on what you've programmed 1 or 2 beats in order to capture the bolus in a subsequent beat. And then the fourth technology on the scanner is called snapshot freeze. This is a retrospectively applied motion correction, which reduces or eliminates residual motion that may have occurred despite the prior 3 technical mitigations that I described. So there's just many ways to get a good study, in the face of variable heart rate patients. The next question that came up directly to me, I'll send to Dr. Dawson, Dr. Baig. Can you describe kind of what you expect to be the downstream impact to your interventional procedures in terms of implementing cardiac CT in your practice? What will be the impact on your diagnostic ICA studies, but will it be counterbalanced by any growth in some of your other interventional procedures?
Yes, that's a great question. So I think that when someone brings in what is at the outset construed to be a competing technology, nuclear versus CT, CT versus cath, I think that the issue here really is are these complementary? And it turns out, in our opinion, they're very complementary. As interventionalists, the last thing we want to do is a normal coronary arteriogram. It is has some complications. It has no upside benefit to the patient outcome, and it costs the system more than we need it to cost for the outcome that you get there. So if we could then take equivocal nuclear scans and do CTs, this is essentially what we're doing. Sujith had mentioned that the insurance payers are already starting to ask the question. We say, hey, we want to do a nuclear scan. And say, hey, have you done a CT yet? Say, hey, we want to do a cath. Have you done a CT yet? So at least if somebody has gotten hold of the guidelines, it's definitely the payers. And so with that knowledge, with either an equivocal nuclear scan or a CT that gives us what the anatomy is going to be, it certainly reduces our normal cath rate, which is what we want to take to 0 if possible, for all the reasons that the impact of the cost and the morbidity of those patient outcomes are. But in addition to that, I think that it's a very complementary technology in that we're able to identify patients with or without disease. So if we're really moving from fee for service to fee for value, over and over doing nuclear scans on a yearly basis will be something of the past. It'll be a CT scan once, maybe once every couple of years, to be able to identify plaque progression, et cetera. And we have multiple clinical examples of where CT has changed the way in which we're going to approach the patient. Not the least of which is the example that I just showed you. The story was the patient had symptoms. It wasn't a classic story, some risk factors, and the CT was completely diagnostic of what we should do next. And I think that same patient could have had a really poor outcome had we not identified that by CT. So I think it completely changes the roadmap of which we use. Okay.
I definitely very true. I think all of it, there's a whole paradigm shift here that's going on, even in structural heart disease. I know CAT scan has already been the hallmark, the landmark for TAVR planning, but as we get to more and more smaller devices and we can reach out to a larger audience and larger population, I think we can try to avoid the bottleneck that is happening where patients are waiting months to get their scans done. I think this gives us the opportunity to reach out to more people and more vulnerable populations so we can get their testing done at a much earlier stage so that we can take care of them before more serious events happen.
And this concept of point of care is really kind of a central one to this webinar, but also to the way that I think that we see the untethering of these patient evaluations from the local big center into more remote areas potentially, and as you mentioned, in cardiac offices, et cetera. So I think that there's a shift that's happening, and I think Sujith is leading that with their chest pain centers. And I would throw the question out to Sujith. Do you think that the idea of adopting the concept of national chest pain centers is one that has some potential value where patients can go quickly to a center like yours? Do you think this is an adoptable program? Do you think that others will do the same? I think we're enthusiastic about this. I'd love to hear your thoughts.
Thanks, Tony. I think it is. I think that as we make this transition to value-based care, we all recognize, chest pain again has been a challenge because there's a life-threatening group of patients with chest pain, but many of those patients don't have life-threatening chest pain. But just out of fear and apprehension, we treat all these patients the same. I think using CT because it's a quick test, and also kind of stratifying these patients in terms of taking a good history. That's what we've been able to do, and I really believe that model will be successful. We've had several practices come and visit our CEC because they're trying to implement similar programs in their respective regions.
Makes sense.
So great. We're a few minutes away from the top of the hour, so I'd like to thank all of our speakers, Dr. Sujith, Dr. Das, and Dr. Baig. We think this is an important topic to make cardiac CT the standard of care for managing cardiovascular disease. We need better access to scanners. We, of course, need more physicians, more technologists trained, and we need cardiac CT to be more cost-effective in acquiring the technology and in the ongoing support. And these are part of the mission and goals of our Arineta team and our clinical partners. So I'd like to thank our speakers, and I did put in the chat my email contact. If you have any follow-up questions or interests that we can help you with in your practice, you can send that to me at scott.schubert@arineta.com. Thank you very much for your participation, and we'll conclude this webinar.
Scott, thank you for the invitation.
Thank you.
Thanks, Scott.